Hey guys, so not the best format, but a recorded lecture here for bone densitometry, chapter 19. You should be listening to this either over the break or the first week back from the break. It is June 13th when I'm recording this thing, anticipating, so it's the week before finals week, anticipating that I'm going to be very, very busy in the next 2 weeks. Got that conference coming up. That's where I'm going to be instead of being in front of you in the classroom. So remember the first week back, we don't have in-person classes. Not sure what Mr. Shepard will be doing with REIE, but for me, we're doing it's Densitometry lecture, so that's what this is. All right, let's get into it then. So we're going to talk about what is bone densitometry. It is um, a specialization, very much like CT, MRI, nuclear medicine, so it's a modality. It's got a very limited scope as far as the exam itself, but the exam is technical and does require special application of physics. Um, Low energy beam absorption or attenuation versus high energy beam absorption and the differential between those. And understanding that lends itself to the understanding of what we're really doing with a bone densitometry machine. So I'm going to talk to you about the exam itself. Most of the time when you do a bone densitometry test, it's the same for every patient. So they measure bone density at particular anatomy from particular vantage points, typically the lumbar spine from an AP or a PA, and then the hip from an AP hip. Um, then typically the way bone densitometry works is you do many studies on the same patient over the course of every 6 months or every year, and you track progression or regression of calcium levels in the same anatomy and compare like L3 bony calcium score. That is essentially the density of calcium in the bony matrix versus 6 months down the road versus another year down the road. And is the calcium score decreasing over time, or is it increasing over time, or is it staying the same? Increasing over time gets you into a diagnosis of osteoporosis, and get you that the doctor might take that result and say, okay, well, we need to do this and this. And they can also, in bone densitometry, not only can they measure the amount of calcium in your spongy bone, um, so compare you to the demographic norm. So let's say you're a 45-year-old female. They they have statistical models of where your bone density should be, and then they can plot like data versus a statistical average for all people that are roughly 45 years of age and female. What's the average bone density for that group, and then what is your bone density? So you get you you can track the progression of an individual, but you can also map that individual and their individual scores against what we know is um, the collective data set, that is the average for human beings. And so those are the way we measure bone density in the bone densitometry exam. As we get into this, we are going to talk about bone biology, structure and function. Should have explained to you how bones grow and form, the various specialized cells that maintain the bones. Some of those cells build up the bones, some of those cells remodel or erode the bones or reform the bones, that is, take calcium away from this little region and then move it and place it in another little region. That's a remodeling process. And that happens on the cellular level, and so we'll walk back through that. Manifestations of osteoporosis. We're going to give you some facts and figures on that disease. It's a very serious and very widespread and common pathology, and it can lead to some adverse health effects regarding mobility and overall health in certain populations. Okay. Data analysis, distinguish between the terms precise and accurate. So, but precision does not necessarily mean accuracy, and accuracy does not mean precision. Those are talking about two different things. So I'll explain to you what those things are in the course of the lecture. So, and then the core competencies required for licensure. So one of the things we do with this lecture is teach you how to get a license in bone densitometry. You will need to have passed your primary certification exam. That is, you'll have to become an X-ray tech first, and then you can go back and get certified in bone densitometry, just like you can get certified in CT or MRI or nuclear medicine or any of those things. There are some requirements for it, and I'm going to lay out, I believe I'll lay out those requirements through the course of this lecture. So, yeah, so bone densitometry. Yeah, I just reset because I forgot a definition, but I remember the definition. So here we go. So bone densitometry is measuring bone mineral content. So content in particular is the calcium atom. And we can measure or we can estimate calcium mineral content by measuring photoelectric absorption, or rather the difference between two exposures, the photoelectric absorption of two exposures. Okay? So we'll get into the science of that, high energy, low energy exposure, and the difference of those a little bit later in the lecture, but that's how we're doing it. And we're specifically targeting calcium content because calcium's got a relatively high atomic number, and so it absorbs or doesn't absorb the X-ray beam in direct proportion to the energy of the X-ray beam. So with low energy X-ray, there's going to be a high probability of photoelectric absorption. Calcium has a high atomic number, so the probability is increased again. And so you get a lot of absorption with a low energy beam of calcium. Calcium absorbs a lot of the X-ray of a low energy beam. But in a high energy beam, you have more penetration power, and so more of the X-ray gets through. But that ratio is consistent for consistent part thicknesses and tissue densities and such. So we can really isolate the presence of calcium and the density of calcium in the bone tissue by doing a high energy, low energy beam, and then looking at the difference in attenuation between the high energy and the low energy beam. We can assess bone strength with it because we know that there's a certain threshold of calcium that's necessary to support the bone structure and then all the additional soft tissue structure that the bone is holding up. We can diagnose osteoporosis with this exam. And then we can follow up on the treatment for osteoporosis with periodic reassessments of the same tissue, same patient. And so we can track whether the medical interventions, the prescribing calcium supplements and maybe certain hormone therapies or so on and so forth, are those effective in this patient, or different interventions necessary. So that can be assessed with follow-up bone densitometry and a tracking of a singular patient over a long period of time. And then along with assessing bone strength, we can give a rough prediction to fracture risk, because below a certain mineral content threshold and below a certain density, the bone is prone to collapse under itself. And so compression fractures of lumbar vertebrae are one of the most common. There's two really that are very, very common: a hip fracture and a compression fracture of a lumbar vertebrae. Those are the two most common fractures for result of osteoporosis. That is, they're specifically caused by the bone tissue thinning out excessively at those two areas. So we can make some kind of fracture risk assessment with bone densitometry. Have to start over again. All right, I finally figured out how to slide advance. Okay, so bone densitometry uses ionizing radiation or ultrasound, but most commonly uses a dual energy absorptiometry, which means we're comparing the absorption rate or the attenuation rate, if you like, um, of a low energy beam to a high energy beam with a singular detector and merging the data sets, the image data, if you will, uh, by subtracting one from the other, you get a composite image that reveals the calcium content of the tissue in question in the beam. Okay, so and that's where the word DEXA comes from, is dual energy X-ray absorptiometry. Okay, DEXA for short. Right. So DEXA advantages: low radiation dose. We don't need to use as much radiation as a conventional X-ray beam. We actually use a pencil beam. So the beam is kind of shaped like a laser beam. The collimation is extremely tight, and it only goes through probably a circle, probably the radius of a centimeter or two. So entrance side probably 1 centimeter across, exit side 2 to 3 centimeters across, because it does expand as it travels through space and through the patient. The beam will expand, but aggressively tight collimation, so we're not radiating a whole lot of tissue here. It's not like we're opening to 14 by 17. It's literally, we call it a pencil beam because it's shaped like a pencil. Now it's still an expanding cone, so to speak, but it's a very, very narrow expansion. It doesn't expand much. Bone densitometry is readily available. It is very cheap and easy to install these machines. The machines are not very costly. They are unitaskers. They're not as versatile as any other imaging equipment. They can only really do this one exam, but they're specifically built to do the bone densitometry exam. Okay, they're simple to use. They use a conventional X-ray beam, and the software does, so there are statistical calculations being done in the analysis report, but the software usually does those for the technologist. All the technologist has to do is energize the machine and take the exposures. And the machine does the rest as far as mapping the attenuations and calculating the difference in attenuations and making that and then recording that data in a meaningful way, the report that's printed out, such that the radiologist can make a diagnosis. Okay, so it really doesn't use the image. It will give you a thumbnail image on some of these, but it really doesn't like report an image as much as it does report the numbers, the statistics about that image, the difference in attenuation, and the projection of, the mathematical adjustment of that difference to calculate a calcium score or a density score. Okay. And then compare those to previous exams in the archive and statistical averages, which are usually in the long-term memory of these things. Okay. Short scan time, it takes less than 5 minutes to perform a bone density test. It is all on projections. Again, we're really not taking images of the bone. Um, it's usually 2 or 3 projections for most protocols. Um, High resolution images, again, the images are not the focus necessarily. Now they are high resolution, the spot images that you get, because the beam is so um, restricted. And so there's not a lot of scatter created with a highly constricted beam. And so the image you do get is high res. But again, that's not where the real important information is. The real important information is in the analysis, the charts, the graph, the data tables that accompany the high resolution image. And then bone densitometry machines are precise, and what that means is it measures density, bone density consistently over time. So precision means that, like if you have a precision ruler, every time, let's say you measure the size of your wallet or the size of your favorite hairbrush, okay? A precision ruler is going to give you the same measurement every time you measure it, okay? Be a really weird rule to, or a world, if you had a ruler and you measured your hairbrush, so, oh, it's 7 inches long, and then you come back this afternoon, same ruler, same hairbrush, but now it's measuring 9 inches long. You would start to question that ruler, right? Question your reality, one. Well, a bone densitometry machine has to be precise. That is, if um, if I see 2 patients and they both have um, roughly the same calcium density, then I should get the same similar numbers, similar measurements from both scans. That's what precision means. It means repeatable. It means when you run the exam, get consistent result. Okay? And then stable calibration. It doesn't fall out of calibration as you run the exam, and typically we don't see these things run out of calibration. Um, it's it's pretty straightforward. It is measuring the strength of the exposure of the remnant beam for high energy, low energy, subtracting the difference of the exposure, and then making calculations based on the difference of the exposure. And so the strength of the remnant beam is largely based on physics and what is your energy of your X-ray beam? What's your part thickness? That's not changing from. So the energy of the X-ray beam is changing. That's the variable. The part thickness isn't changing. The actual density or calcium content of the tissue is not changing from the first exposure to the second exposure. So the only thing that changes is the energy of the beam. And so the physics is consistent. If we get a difference of exposures in the remnant beam, that is, the strength of the remnant beam displays variation, we can attribute that variation to the difference in energy. Okay, and then we can make some mathematical assumptions about the tissue density and type, that is it calcium, or how much of it is calcium, and make some really, really accurate predictions with a stable calibration machine. Okay? Yeah. Bone biology. Your bones are constantly reforming themselves. In your younger years, they're growing longer and thicker. But in your older years, they still remodel themselves. And so you get new mass is deposited, old bone mass stripped away, and even though the shape of the bone on the macro scale, that is in gross anatomy, is not really changing, on the molecular scale there's a lot of work going on as far as building new bony matrix here and thinning out bony matrix in other places. Now this process is radically shifted toward new bone formation all the way up until somewhere in your 20s, and it's different between men and women. But you reach peak bone mass in your 20s or 30s. Okay, your bone mass is relatively stable from that point, so it's basically in balance. That is bone erosion or remodeling, and that is the reabsorption and the formation. Toward formation in your early life. In your middle life, those two processes are in balance, and then later in life, resorption starts to surpass new bone formation, and so you start to get decreasing bone mass. In women, this begins at age 50, in men, age 65. Okay. So we know these things from studying human biology over thousands and thousands of years, all the way back to Leonardo da Vinci. Okay, so these things are when we speak about these numbers here, these are statistical averages for human population. Okay, there are going to be variants across certain genetic subtypes, like Caucasians versus Mongoloid races versus African races. Yes, there is going to be genetic variation to these, and if you become a bone densitometer, you might learn more about that. It's not really important for this lesson. We're just giving you an introductory dive into what this is all about. So, okay, so these are our bone cells here, and so resorption, okay, results in the pink is the bony matrix, the calcium phosphate stone, if you will. And then those brown rocks with the dots on it, those are either osteophytes or osteocytes. And they either reabsorb the bone or they form new bone. And so from A to B, we have, I think, osteophytes resorbing the bone, or, pulling the calcium phosphate up out of the rock formation and essentially dissolving the rock in focal areas. And then in slide C, osteocytes come in, and they actually deposit new bony matrix, okay? And then ultimately we get to a completion status, but completion, from my understanding, doesn't last long. Both processes are continually ongoing. They do concentrate at the joints. They concentrate at the epiphyseal plates during the growth cycle, and they concentrate at points of bony injury, like a fracture. You will see a huge uptick in bony metabolism post-fracture, a lot more resorption, or not necessarily resorption of the fragments, but new formation, healing the divide of the fracture. So both types of processes going on. If there's any avulsion or splintering or shards of bone, those are usually reabsorbed completely, and the calcium and the phosphate that's reabsorbed from those shards are immediately donated to reform the fractured bony lattice or bony tissue at the molecular level. Okay. So osteoporosis is a chronic pathology. Is type 1 and type 2 primary. Type 2 is secondary to pregnancy, but I'm not certain about that. Let me be sure. Let me advance the slide and be sure. Roughly 10 million persons in the United States have osteoporosis. Osteoporosis is much more common in women than in men. 80% of women will get osteoporosis in their lifetime. Okay? Two types, primary and secondary type. Primary type osteoporosis is osteoporosis itself, type 1 and type 2. I believe type 1 is um, a degenerative, that is, old age is the root cause. Um, type 2 is secondary to pregnancy, but don't quote me on that. So what is secondary osteoporosis? Secondary osteoporosis is secondary to bone cancer or some other primary pathology that is causing osteoporosis as the pathology manifests. So if you get like I think it's a sarcoma is the destructive, technically the sarcoma is causing osteoporosis. So that would be secondary osteoporosis, secondary to the sarcoma. Right. So your risk factors. Are you female? You have a higher risk for osteoporosis. Um, risk of osteoporosis. Do you have estrogen deficiency? You have increased risk for osteoporosis. Are you Caucasian? You have increased risk for osteoporosis. Do you have a low body weight or a low body mass index? Are you skinny? You have increased risk for osteoporosis. It turns out that the fat cells can also store calcium ions. So having a little bit of fluff or padding will serve you well in your old age. Okay? Family history of osteoporosis or fractures in old age. You're genetically predisposed to osteoporosis. You're very likely to have it in the future if your mother or your grandmother suffers from it. Okay? History of prior fracture as an adult. Okay, male or female, if you've ever broken a bone, you could get focal osteoporosis at the fracture site as you get older. And then smoking tobacco strips the calcium from your bloodstream. It pulls the calcium and you don't have the appropriate levels of calcium in your blood, and then your physiology alters to borrow calcium from your bones to keep the calcium supplying your blood at the correct levels. So, and then we have those are actually cadaver lumbar vertebrae. The one is a normal one. You're supposed to see that the spongy bone is thicker in the normal vertebrae. The one that's been collapsed, the spongy bone is supposed to look thinner to you with a lot more open spaces and a lot less of those cobweb-looking angled web, the trabeculi. So there's not as many trabeculi on the compressed vertebrae, and it's called a compression fracture versus the normal vertebrae. There's more bony trabeculi in the normal vertebrae. Okay, anyway, bone health recommendation. National Osteoporosis Foundation's bone health and prevention recommendations. Obtain daily recommended amounts of calcium and vitamin D. Okay, vitamin D you can get either in supplement. Might find those in avocados, but look on the internet for which um, are rich in vitamin D. Vitamin D fortified milk is definitely rich in vitamin D. You can also get vitamin D from sunshine. That's right. Human beings can make their own vitamin D if they just expose themselves to natural electromagnetic radiation. It's almost like magic. So you can, going out in the sun, you actually make nutrients that make your bones stronger. Okay? Engage in regular weight bearing and resistance exercise. Remind me to tell you about the time I was an X-ray tech for the Nashville Predators and what their calcium looked like in their skeletons versus the folks I encountered in the hospital. Oh my God. All right. So if you want a nice, healthy skeleton, beat the crap out of yourself on a regular basis through rigorous physical exercise, and you will have the strongest skeleton I have ever seen. Okay. Avoid smoking and excess alcohol. Both of those um, result in an altering of the physiology of the bloodstream, and your calcium levels suffer as a result of smoking and alcohol consumption. Okay. Talk to our healthcare provider about bone health. Most general practitioners are familiar with osteoporosis. It's widespread enough that you can just see a general. You don't have to go see a specialist necessarily. You can go see a general practitioner and they will be able to educate you on bone health and osteoporosis. And then have a bone density test and take medication when appropriate. I would recommend that ladies get a baseline bone density test in their late 40s, okay? Because we know that the statistical average is bone mass loss begins sometime around age 50. So if you're 45 and female, not had your baseline bone density test, you probably should consider it. All right, physical principles. It's a subtraction technique. So we're going to use a high energy beam and a low energy beam. You don't have to switch it manually. The computer is going to run a certain protocol when we press the exposure button. The first portion of the beam will be like 60 to 65 kVp. The detector will measure the remnant beam exposure, and then it will automatically, mid-exposure, boost the kVp to something closer to 100 kVp. Now, are those energies exact? No, but it is going to go from low energy to high energy, okay? And then it'll collect more data on, and there should be a difference in the strength of the remnant beam because the penetration power of the beam is increasing and nothing else is changing. And so by subtracting the strength of the low energy beam from the high energy beam, we can map a profile and isolate tissue that basically has calcium in it because it allows us to subtract away the soft tissue and isolate just bony tissue with the dual energy. Okay. Okay. So this is how our machine is set up. We have X-ray tube letter E. Notice that looks like a stationary anode Coolidge tube to me. We don't need a rotating anode because we're going to do like 2 exposures and then we're going to rest the machine for about 15 minutes or so. At level D, underneath the patient, we have a series of filters. So aluminum, copper possibly, multiple, and so the protocol will, the machine should, when we set up the protocol, the machine should set appropriate filtration automatically. It's not something the technologist, unless the technologist is doing something special, technologists shouldn't be deviating from the software protocol, and so the machine should control what filtration goes in and what filtration doesn't. And there might be a difference in filtration between the high energy and the low energy beam. Okay. Letter C is a laser and a targeting mirror that is radiolucent. Okay. So we can see the laser beam would strike the patient's abdomen, and that's going to model where, model, M-O-D-E-L, where the X-ray beam is going to exit the patient from inside the table. And so we can use the laser beam mirror, 45-degree angle mirror, to kind of center the patient appropriately for the measurement. And then letter B is a detector that is calibrated for low energies. And then letter A is a detector that's calibrated for high energies. So first part of the exposure, second part of the exposure. Those are two different detectors, two different data sets, and they're only merged once they become electronic data in the computer. Okay? So that's how a typical bone densitometer works. The dotted blue line is the X-ray beam. Right, so what is that doing as far as the data set that you're capturing? Well, when you use high energy X-ray, it penetrates everything, so there's less attenuation everywhere. When you use low energy X-ray, there's more probability of absorption, and that absorption occurs maximally in bone tissue. And so when subtracting these two things, the soft tissue is mostly going to be the same attenuation from high energy to low energy, but the bone tissue is going to show a radical change in attenuation between low and high energy. So we can isolate the bone tissue by subtracting them away, and that's where we get, so the absolute value of low minus of the low energy minus the high energy, the intensity of the low energy minus the intensity of the high energy, and then K is just kind of some kind of fudge factor that the physicists have figured out to adjust for and estimate calcium score or calcium density or whatever. So that's that little K is a little multiplication factor number that is stuck in there to change the change in attenuation into a prediction of calcium content or prediction of calcium density, depending upon what software is using. Okay? So it's calculated by proprietary software, but we understand the physics. We understand photoelectric effect is being manipulated. At low KVP, photoelectric effect is more probable. It's most probable always with higher atomic number target atoms. And so we're going to see a difference across all tissues between low energy attenuation and high energy attenuation. But calcium, tissues that have calcium are going to have an even greater difference than all other tissue types. Okay. Different manufacturers will have different methods of like different energy ranges that they're utilizing. As long as they use one low energy and one high energy and use a difference, their mathematics is similar across all softwares, but all softwares are not exactly the same. And so one of the troubles with bone densitometry as a monitoring type mechanism is you have to explain to the importance of to your patient that when they get the follow-up exams, they get it on the exact same machine because each machine is calibrated according to that manufacturer. And if they go to a different provider, they might use a different machine made by a different manufacturer and a different method of calculation, and then you don't have comparable results without standardization. So, so it's a little nuance. So long as if you find yourself in the future that you are a bone densitometry patient, just understand that you're better off as far as long-term tracking of progression. You're better off going to the same provider over and over, like every 6 months, every year, every 2 years, whatever it is that your physician recommends the follow-up frequency is. Just remember that you should go back and get the exam done on the exact same machine that you were first diagnosed on, and that the data is more useful because they don't have to compare across different machine types. Okay? So originally we used a pencil and a single detector. Newer technology does use a fan beam with a multi-element detector. So it's very much like a CT scout image in the newer ones. Resolution, we're still, because the shape of the beam is still so small, uh, not getting a lot of scatter generation. Therefore, we're getting high contrast resolution with these images. But again, the images is not the story for bone densitometry. The images are secondary. What matters is let's get a realistic score. By that I mean accurate score of what is this patient's actual calcium content of their bones, and that's the real trick with a quality bone densitometry scan is are we when we calculate and publish this measurement, does it reflect the truth? And so that's where we get into the statistics. There's the mean, which is the average, okay? So like a mathematical mean, not like somebody with a bad attitude. It's the average of a group of numbers, okay? Standard deviation, which is another statistical measurement that talks about not necessarily where your average is, but how far does the rest of your data spread from your average? Is it um, is it a skinny bell curve or is it a fat bell curve? That's what standard deviation is telling you. And then percent coefficient of variation, that's the best number to um, kind of objectively view the data if you happen to have a patient that is getting scans on multiple different machines from different manufacturers. Percent coefficient of variation gives you kind of an estimate of how universal is this compared to other machines type thing. It's a comparison of, okay, machine A was made by GE and it measured I don't know, a calcium score of, I don't even know what the calcium score scale is, let's say 10. But then you went across town for your 6-month follow-up and they used a Philips machine and they scored you at 12. Well, is the 12 really different, or is it different because you got scanned on a Philips machine instead of a GE machine and the software does the calculation just a little bit different? That's where coefficient of variation comes in. They can manipulate the numbers a second time and get like a relativistic comparison across different machines with coefficient of variation. Okay, so the average is the sum of the data values divided by the number of values. The more values that you have, the more meaningful these numbers become. And that's for all of these numbers. Standard deviation, a measure of variability, measures the spread of the data values around the average. So the average is typically thought of as the truth. All right, so let's say in the course of a single exam, you take 5 measurements because that's the facility protocol. Instead of just a single measurement, you take 5 measurements and you average those measurements. Okay, that number, if the machine is running right, should be more accurate than any of the individual measurements. Okay, because it takes into it kind of removes difference by variability. Did the patient shift position? Did you not center them appropriately? Taking a breath when they should have blown their breath out? Those type of variances can affect tissue density and position and can also introduce motion if the patient's not paying attention. And so they can affect the measurements. But if you're averaging multiple measurements, you can kind of get rid of some of that variance. Okay. So the average has more significance as regard to adhering to the truth. Let me shut my door, hang on. So, yeah, Mr. Shepard wanted something. I apologize. Um, by means of taking an average, you kind of decrease the variability. Average is closer to true measurement than any individual measurement. And the more measurements you take, the more truthful the average becomes. Okay? A standard deviation is going to give you, it's a mathematical manipulation that's going to tell you about the variability of your measurements. Okay? So you can have a number range of, let's say you can have calcium scores from 10 to 20. And if they're evenly spread, you'll know that the average is 15. If they're asymmetrically spread through that range, then the average will be lower than 15 or higher than 15. But if they're symmetrically spread through the range of 10 to 20, that means there's an even number of points below 15 and an even number of points above 15, and you have a symmetric distribution, and therefore the average is 15. But you can arrive at an average of 15 with the range not from 10 to 20, but from 0 to 30. You see, so the whole graph gets wider. It's still symmetric distribution, still ends up with the same average, but now your scores are kind of all over the place, so to speak. Okay, so standard deviation is really telling you how much does each individual measurement compare to the average. That is, how closely together are each individual measurement. So it gives you an idea of the precision of the machine. Okay, the average itself is aiming for the truth and is a good aim at the truth. The standard deviation is telling you information about the precision of the measurement. That is, how consistent is the machine measuring that specific value, like 15. Okay, how close are you coming to 15 every time? Okay, if you're always getting really, really close to 15, then your standard deviation is small, and that means you have less variability in your measurements, and the measurement is more believable because it's more precise. And that's where we get into the difference between precise and accurate. Okay. Now, percent CV, remember I said, comparison of variability between different data sets means that you can compare the GE statistics on a singular patient to the Phillips statistics. Okay, so what you do is to record the percent CV, it's the standard deviation divided by the mean times 100. Okay, with a smaller CV ratio percentage, there's less variability, and therefore smaller percent CV means that the measurement you've taken is more believable. Okay? Because you're not getting a lot of variance in your measurement. And that's how you can tell the difference between a GE and a Phillips is one of them is going to have a smaller percent CV. If one has a smaller percent CV, then those measurement numbers are more believable than the other measurement numbers. If the percent CVs are the same, then both numbers are believable. See how that goes? All right, so this is an example. The green data set and the red data set both deliver the same average, which is represented by the blue line. But the red data set has twice the standard deviation of the blue data set, or the green data set. And so the percent CV is smaller for the green data set. And you would say if this was two different machines, you would say the green data acquired by the machine, that's the green circles, is a better bone densitometry machine than the data acquired by the red machine. The red machine is scoring all over the place with wide variance. Okay, whereas the green machine is more precise. The accuracy is the same because the average is the same for both data sets, but the precision is better in the green machine on this slide. Okay, that's the difference between precision and accuracy. It's how tight together are the measurements. So this is a typical bone densitometry report. Again, they call this a high resolution image. It looks a little blurry to me, but whatever. The image is not the point of the exam. The point of the exam is the chart and the data over here. It's giving you the bone matrix density in grams per centimeter cubed here at the bottom at B2 and B3, and then the difference of B2 and B3, or the average of B2 and B3, okay? Then an age-matched score in step 3 is telling you what variance are you versus average for a human population. And you can see in the color chart there, this is bone density in grams per centimeter squared. And this is the black square is where the patient has measured today. And then the blue, slate blue, kind of grayish blue, I guess. That's what I call it. That's like human beings average. So the black line in the middle of the blue is exactly average. And then 50% of the people are above average and 50% of the people are below average. Looks like this person is within the norm, but is slightly below average for their age. Okay? They are only, 33 years old? 32.4 years old. So on the x-axis, on the bottom scale, is and I don't know what the t-score is and how to calculate that. I do know what bone mass density in grams per centimeter cubed means, though. So I can read the y-axis on the left and I can read the x-axis on the bottom and understand those two. And so it looks like this person is just below average, but they're not in any kind of danger zone. And you can see that the human population average bone density drops somewhere after age 40, and it ends at about a 45-degree slope until age 60, and then at about a 30-degree slope after age 60. And then it gets and then you can see the color codes. Those are your fracture risks. So the green zone, that's considered healthy bone strength. And then in the yellow zone, that's considered at risk. And then high, moderate, and extreme risk are the orange and the red zones on that chart. So pretty easy to understand. Even if you've not been trained in bone densitometry, you can figure out what they're trying to show you there by looking at the chart, and that's giving you more information than the x-ray is actually giving you. So the x-ray is only showing you where the measurements were made, so to speak. Okay. So accuracy versus precision. Accuracy is the ability of a measuring instrument, like a bone densitometry machine, to measure the true value of the object. So we want the bone mass density in grams per centimeter squared. Okay. If our machine is well calibrated, then we should get with full measurements in a single day and averaging those values, we should get to the average should start to look like the truth. Okay, if our machine is running properly. Now, precision is, much does the machine agree with itself? That is, the scan you just did showed a bone mass density, I don't know, of 0.65 grams per centimeter cubed. Okay, now you're repeating the scan to get more data, and it reads out at 0.62. Well, that's pretty close. Okay, it's not exactly 0.65, but it's not 0.59, it's zero point 0.6 something. So you're accurate there. What's the difference between the two measurements? 0.65 and 0.63 are 2/100ths off each other. That's the difference between their values, 2/100ths. So about 2% variance, okay, on a 100 scale. And that's not even percent CV calculation, okay? It'd be much, much smaller if it was percent CV calculation. But you get the idea. The drift in the measurement from one measurement, and now I'm going to do the exact same measurement, like you would totally flip out if you measured an object with a ruler and you got 7 inches, and then the next time you got 8 inches, and the next time you got, I don't know, 6.5 inches. You'd be like, what the hell is going on here, right? If you measure an object with a ruler and you get 7 inches, the next time you measure that object, you expect like, I don't know, 7 and 1/16, or 7 and, or 6 and 15/16, right? And what you expect is precision, okay? So, yeah, getting, anytime you're conducting measurement and you repeat the measurement and your result varies wildly, that leaves you with doubt as to, okay, how good am I doing this measuring? You see what we're saying? So precision is just as important as accuracy. Okay. Explain to you in terms of archery. Okay. So if you have two individuals learning archery, or 3 individuals learning archery, student A, student B, and student C, they're all aiming for the bullseye. That's important. They're all aiming for, because the bullseye represents the truth. Okay. Student A is precise. See how tight the arrow points are? The grouping is? That is, every time they pull the bowstring, you know where the arrow is going to end up. It's not going to end up at the target, which is what you want. It's going to end up in the left upper quadrant of the bullseye. But each arrow strike is right up against each. So as far as the mechanics, they are being consistent with how they pull the bow and how they release. They're getting a very consistent or precise result. Student B is going to work on their form. Aim is true, getting close to the target, right? But the arrows are spread out a little bit more randomly and they're farther apart from each other. Okay? So there's way too much variance in the results in student B. It's more accurate than student A, but less precise. They're closer to the truth, but it leaves you to doubt their abilities because of the gaps between the arrow strikes. So you think that they're just getting lucky, you see? So student C is the only one that you would say is a good archer. They are both precise and accurate. Not only are they hitting the bullseye, but they're doing it consistently, and every arrow shot looks just like the placement of the last arrow. That's precision versus accuracy. Okay? You will be quizzed on those for the test, so make sure you really listen to this particular slide again and make sure you understand the difference between precision and accuracy. Letter A is precise, letter B is accurate, letter C is both precise and accurate. Agreement with itself, but also gets close to the truth, the bullseye. Okay, so now that you understand precision and accuracy, one of these measurements was done incorrectly. It's a different result. Okay, so which one of these measurements was done? This is the targeting system for your bone densitometry for a hip. A was done 6 months ago. Which one is going to give you a precise measurement, B or C? you should understand that C was done just like A. B does not look the same as letter A. Difference is internal rotation or external rotation of the toe before you should be doing a slight internal rotation of the toe for a true AP of the hip, as was done in letter A. So when you're doing follow-ups, you always position the patient the exact same way. So letter B is an inaccurate measurement or an imprecise measurement because you don't have the bone positioned the exact same way as it was done the first time in letter A. Letter C and letter A are of each other. They will be precise measurements. They will be very close together. The measurements will be in agreement with very little variance. Letter B is subject to a lot of variance because of incorrect performance. The toe was allowed to roll out in letter B. Or to become a bone densitometrist, you need to pass the exam. The exam consists of these categories. There might also be didactic competencies. They might have updated that information since I researched this slide or researched this field. But as far as I know, the sections for the exam for bone densitometry are what's listed here. Radiation protection, patient care, clinical history, computer operation, scanner quality control, patient positioning, scan acquisition and analysis, record keeping, and documentation. So if you can answer questions about those, similar to the vein of registry content, which you should be able to, you can get certified and credentialed as a bone densitometry technologist. Okay. Insurance reimbursements in the marketplace are going to mandate that bone densitometries be performed by technologists that have registered in the credential. So you probably won't get much work as a bone densitometrist unless you have the bone densitometry certification. Okay. Yeah, that's about it. It doesn't sound like too hard of an exam. It sounds like there's a lot of overlap between this and the primary certification, primary discipline exam. Right, so in addition to the regular survey exam, um, central skeletal measurements, total body composition measurements, you can do a pediatric assessment and peripheral skeletal measurements, but it might be that the calculations are slightly different for those other bone densitometry procedures. So you really should be, first of all, you should be a registered bone densitometrist before you're taking on things that are outside of the ordinary. And you should make sure that your machine is capable of doing those protocols because the calculations might vary. If I would say, like, if you're doing, let's say you've got a diabetic foot and they're doing a study on the osteomalacia, the progression of the infection in the foot and whether or not they have to amputate. Well, you might do a bone densitometry on such an individual. I might dare say that because the pathology is different and the body part is different, that the calculations for the bone densitometry might also be different. And so you might need a special software package for that. That's not 100% certain. That's a speculation on my part, but I think it's a reasonable speculation on my part given what I understand about the physics and how the analysis is performed. Um, it's measuring for differences in attenuation. Well, a diabetic foot is going to have effusion and chronic inflammation, and so it's going to affect attenuation. And so, does that have to be accounted for in the fudge factors and the mathematics? I think it does. So these are actually CT scan images, and some of your CT scanners now have been outfitted with bone densitometry subroutines and protocols, so you can actually a CT scan tech, if you have the right software downloaded. Again, you got to have the bone densitometry software package. But Hounsfield units are essentially attenuation measurements. So Hounsfield units or CT numbers can be converted very easily with different formulations programmed into the software, but you can make accurate measurements of bony mineral content with a CT scanner. There's no reason you wouldn't be able to. So whatever a bone densitometry unit can do, a CT scanner could do. You just have to have the right software installed on the CT scanner in order to run the calculations you need. Okay, it's a given with every bone densitometry unit can do that because that's the point of the machine. A CT scanner is to do CT scans. If you want to do bone densitometry, it's usually a software add-on uh, bare bones unit. Okay? So that's bone densitometry in a nutshell. Okay? Talked about bone biology and the remodeling, that is the formation of new bone matrix and the reabsorption of bone matrix, and how those things are, sometimes they're in an imbalance, sometimes those are balanced. We talked about the various forms of osteoporosis, whether it was a primary or secondary. I believe the type 2 was postmenopausal. I did look that up during a break. So it's type 2 is postmenopausal, type 1 is just old age. And then secondary osteoporosis is like you have bone cancer or bone mets, and then your bone tissue thins out as a result of the primary. It's the bones, or the bone cancer. The secondary pathology as a result of having bone mets is a thinning of the bone tissue. So, physical principles of a DEXA scanner: it's going to be an X-ray tube, usually set up like a fluoroscope. So the X-ray tube source is in the table. The beam projects upwards toward the ceiling, and a detector or multiple detectors are fashioned above the patient. There's a targeting laser above the patient with the detectors, such that you can center accurately according to positioning landmarks. Typically the DEXA machine, DEXA stands for dual energy X-ray absorptiometry, so you need to use, the machine should be utilizing a low kVb exposure and measuring attenuation data from the low exposure, and then measuring attenuation data from a high energy exposure in follow-up, and then there's a subtraction of the two data sets. The data analysis usually involves calculating an average bone density at multiple different measurement sites or multiple measurements in the same visit. Densitometry usually is a chronic, is usually following osteoporosis, which is a chronic condition, so there's follow-up bone densitometry studies done periodically, either annually or semi-annually, to monitor the progression or the effective slowing down with prescription intervention of the osteoporosis. And so we need follow-up studies done for our osteoporosis patients. Okay. Core competencies required for licensure: those manifest as both didactic experience, but then also those are the sections of the exam as well to receive the credential for bone densitometry. It's one of the easier credentials to receive because so much of the science part, the physics part of the exam, overlaps what you already know as regards to the physics of the X-ray beam and how it interacts with tissues. The new part of that, the new technical part that might give some applicants trouble is the statistics and understanding averages and standard deviations and percent variance, the percent CV measurement, those type of things. Those would be the new stuff that would probably be challenging. The rest of it's just going to be knowledge of anatomy, knowledge of bone physiology, patient care, radiation protection, stuff you should already know, really. So, without becoming a mammographer, I highly recommend. So, seeking a certification in bone densitometry, because usually the bone densitometry machines are at the mammography clinics, because that's where you're finding the most customers. It's a women's health type situation. So, certify, and you are more higher mammography tech. There's only one primary type of osteoporosis, and it is caused by old age. Is that true or false? It's false. Type 1 is caused by old age. Type 2 is caused by menopause. All the following features of bone densitometry examinations, except assessing bone strength, evaluate and stage bone cancers, monitor therapy, and predict fracture risk. And a bone densitometry exam can do all of those except for E, evaluate and stage bone cancers. Which of the following are advantages of DEXA? Low radiation dose, readily available, high resolution images. And the correct answer is all of those are advantages of DEXA versus normal radiographic studies. And that is all we have for this lecture. All right. We'll see you guys the week we get back. See some of you guys at my birthday party this weekend. King of the future again. This is still being recorded on June 13th, but by the time you hear it, my birthday party will be this weekend. So see you there. Bye.